Welcome to Chapter 7, Language Disorders in Early and Later Childhood. Our focus questions for this chapter are: what is a language disorder? How are language disorders classified? What are the prevalent types of language disorders? How are language disorders identified? And how are language disorders treated? We'll look a little closer at all of the answers to those questions as we discuss this chapter. Language disorders are delays in critical language precursors in the first year. Slow to achieve important language milestones in toddler and preschool years is one of the characterizations of a language disorder. Another sign of a possible language disorder is if the child struggles with academic skills that rely on language proficiency in the school age years. And children may face ongoing challenges in living and working in adult years. A language disorder refers to impaired comprehension and or use of spoken, written, and or other symbol system. It may involve form of language, content of language, and function of language. Social, psychological, and educational impacts are additional considerations in defining language disorders. They can play a part in the language disorder. A language disorder versus a language difference can be characterized when you establish that a child has a disorder involving examining a child's language skills relative to both normative expectations and cultural expectations. Um, that'll be defining a language disorder. And if they have a language difference, it may be dialectal in nature. The meaning of significant. A definition of a language disorder also must specify the difference between language difficulties that are not serious enough to be classified as disordered and those that are. By many accounts, a language disorder is present if significant problems are present. However, you should note that it's difficult to determine when a child's language problems are serious enough to be called significant. In looking at whether there is enough of a significance to call a disorder or to call learning differences or language differences a disorder, speech pathologists and other professionals who diagnose the disorders tend to rely on the use of tests. Sometimes the scores, norm reference tests, are not always definitive in determining whether a problem is significant. So sometimes norm reference tests can be used in addition to observations or interviews with parents, just to name a couple. Current terminology that we use is our language disorders, language impairments, language disabilities, and specific learning disability. Those are in contrast to outdated or inaccurate terms or names such as language delay, language disability, language learning disability, childhood aphasia, and language deviance. The column on the left is what we use currently. And these probably will change again in the next few years. It seems like terminology kind of goes in cycles or changes over a period of years. Prevalence and incidence of language disorders: about 15% of toddlers are late talkers. And in the book, it talks about late talkers a little bit on page 203. Children who show delays in the earliest stages of language development are termed late talkers. Approximately half of these children will catch up with their peers by 3 or 4 years of age, whereas the other half will continue to show ongoing difficulties with language development. Late talkers who end up catching up with other children may be appropriately described as having a language delay. Primary language impairment affects about 7 to 10% of children over the age of 5. About 1 in 1,000 children exhibit mild to severe intellectual disability as a result of Down syndrome. About 1 in 68 children exhibit autism or an autism spectrum disorder. And actually, recently, I have heard that number as low as 1 in 45. Approximately 2% of children experience significant head injuries each year. 582,000 received services for intellectual or hearing impairments and traumatic brain injury. 1.4 million 3 to 21-year-olds received services for speech language impairments. And that population from 18 to 21, I'll point out, you might think, well, at 18 you graduate from high school, but some children who have more severe intellectual disabilities can be served through the school system up to age 21. How are language disorders classified? Language disorders are usually classified according to etiology, manifestation, and severity. And we'll look at each one of those a little bit closer on the coming up slides. The etiology is the definition of that refers to the cause, in this case, of language disorders. Primary and secondary disorders. A primary disorder occurs in absence of any other disability, like a standalone disability with nothing else going on as far as late milestones or having the child needing to be served with any other services. Secondary disorder occurs in result of another disability. For instance, if a child has Down syndrome, um, they are going to also have mixed expressive and receptive language delay as part of having Down syndrome. The disorders come in two different types: developmental, meaning present from birth, and acquired, meaning it has been acquired sometime after birth. Let me go back to the primary and secondary disorders for just a minute to be a little bit more specific. Um, Under the primary disorder of language, children will receive special education services in schools because of speech and language impairments. For the secondary disorder, it's a result, could be also a result of intellectual or developmental disorders or brain injury. Manifestation, excuse me, referring to the comprehension and expression. Some children exhibit significant problems with comprehending language but have normal expressive skills. They have a language comprehension disorder. Other children have problems only with expressive language, and they would be considered to have an expressive language disorder. Specific expressive language disorder is another term that could be used with this. A mixed receptive expressive language disorder can be given to children who show impairments in both comprehension and expression. It can manifest itself in with form, content, and use. And what is something called a focal disorder? A disorder affecting only one domain is called a focal disorder. whereas a disorder affecting multiple domains is referred to as a diffuse disorder. Typically, a diffuse disorder is less likely to resolve and is viewed as more serious than a focal impairment. Language disorders can manifest themselves in reading and writing, in the areas of decoding, which involves applying an alphabetic language such as English, Spanish, or French, involving applying alphabetic principles to identify the spoken word that corresponds with a written word. Also manifest itself in reading and writing under an alphabetic principle, which is the understanding that speech and print correspond in a predictable, systematic fashion. An example of that would be that the letter K and the letter sequence CK both make the K sound. A process called reading comprehension is highly dependent on a child's language skills. Decoding and reading comprehension are key to being able to read. Dyslexia. Children with poor phonology who show extreme difficulty learning to read words can have dyslexia. However, there are also children who develop good decoding skills, but who then have unexpected difficulties with reading comprehension. These comprehension problems are attributable to core deficits in language ability, such as understanding grammar and vocabulary. Next, we'll look at severity of language disorders and the range in which those can occur. A mild impairment may be perceptible only to the child, his or her parents, or a professional, and may have little impact on the child's ability to function in social and academic circumstances. Children with mild impairments may not qualify to receive any specialized supports or ongoing interventions, especially in the school system. A moderate disorder or impairment typically will require the child to have some sort of accommodations to perform in social and academic settings and require ongoing intervention by a specialist to improve language skills. If a child didn't receive those interventions, there's a good possibility that they would continue to fall further behind their peers in key language areas. Severe impairments typically require extensive modifications for the child to perform in social and academic settings. From early childhood on into adolescence, children with severe learning disorders will differ substantially from their same age peers in comprehension and in the area of expressive language. In the classroom, a child with a severe disorder might have an assistant who will help them to enter into conversations with peers, prompting them with specific words to use. As that child becomes an adult, an individual with a severe language disorder may not have adequate language skills to understand abstract words that are relating to time, such as past and future, maybe ordering of events first, then, and last. These people can benefit from participation in supported employment opportunities. I know in our county we have Watauga opportunities where a lot of adults go to work on a daily basis where they can work closely with a job coach, and it's considered to be a community work setting. And then the last level of severity is profound. And children with profound impairments may have no language skill at all and therefore be severely limited in their ability to participate in home, school, or community activities. Typically, someone with a profound language disorder will also have a profound intellectual disability. Um, People who have profound language disorders might use and understand very few words or symbols and thus have alternative approaches to communication. If you've ever seen somebody with an OGCOM device, they have low tech devices and high tech devices that are computer based. And depending on the person's capabilities, an appropriate Ogcom device may be chosen for them if they have profound, a profound language impairment. What are the prevalent types of language disorders? Specific language impairment, autism spectrum disorder, intellectual disability, and brain injury are the ones that we're going to look at today. Specific language impairment describes a significant impairment of expressive or receptive language in preschool and school-age children that cannot be attributed to any other causal condition. For short, or an abbreviation of this, is SLI, and children with SLI have typical hearing skills, normal intelligence, no obvious neurological, motor, or sensory disturbances, such as seizures or brain injury. A defining feature for children with SLI is that their language skills seem disproportionately poor relative to their intellectual capabilities. This diagnosis usually comes after a child's third birthday, although they may show signs of this disorder during their first or second years of life. Children who are slow to talk, meaning that they don't say their first words until after 15 months, and are typically classified as late talkers rather than language impaired. And diagnosis of SLI usually not being made until 3 or later, when it's clear that a child is exhibiting a true disorder rather than just being a very late talker. And there's a bullet point highlighting some of the things I just went over for that. Defining characteristics for SLI are that inconsistent skills across different domains, history of slow vocabulary development, a tendency toward word finding problems, specifically difficulties in coming up with the right words at the right time, and considerable difficulty with grammatical production and comprehension that begins during toddlerhood and continues through school age. Causes and risk factors. There are currently no known causes for SLI. Recent advances in technology suggest a strong biological and genetic component to this disorder. Whether biological or genetic predisposition to SLI is eventually manifested as a disorder is linked to a child's exposure to additional risk factors. The next thing we'll look at is autism spectrum disorder, and this is an umbrella term which describes a variety of developmental conditions. These are characterized by significant difficulties in social interactions and communication, engagement in repetitive behaviors, and overly restricted interests. These 3 red bullet points are 3 of the characteristics that need to be present in order for autism spectrum disorder to be a child's diagnosis. They have to have delays in each of these 3 areas. Symptoms must emerge during childhood, affect an individual's everyday functioning, include difficulties with social communication and interaction, and include restrictive and repetitive patterns of behavior. Asperger's syndrome, the onset is could be before or after 3 years of age. No clinically significant delay in language, cognitive, self-help, and adaptive behavioral skills, but significant impairment in 2 or more areas of the following: social interaction, behavior. This term, as of the DSM-5, is no longer used as a specific diagnosis. However, you will hear people referring to Asperger's syndrome still today, especially parents of children who are high functioning on the autism spectrum. As you can imagine, they would want to differentiate between their child who is higher functioning than, say, a child who is nonverbal and has a diagnosis of autism under that same autism spectrum disorder umbrella. Causes and risk factors. Several risk factors that may contribute to the likelihood of a child's developing an autism spectrum disorder are prenatal and perinatal complications, particularly maternal rubella and anoxia, genetic factors. And it's important to point out that the MMR vaccination does not cause autism, contrary to reports that were put out several years ago stating that vaccinations were believed to be contributing to children being diagnosed with autism. Intellectual disability, the defining characteristics, um, also described as intellectual developmental disorder. It's a condition of arrested or incomplete development of the mind. It's characterized by impairment of skills manifested during the developmental period. Causes and risk factors. 30 to 40% of the cases, the cause cannot be identified. 65 to 70% of the cases, the causes stem from both biomedical and psychosocial factors. 30% of cases can be attributed to prenatal damage. 50 to 20% of all cases are caused by environmental influences or other mental conditions, abuse, or the presence of autism. 10% of all cases are caused from pregnancy and perinatal problems and viral infections. 5% are caused from medical conditions such as trauma, infection, and poisoning. And 5% are caused by heredity alone. Next, we'll look at brain injury. Um, the definition refers to damage or insult to an individual's brain. Brain injuries can occur in utero, perinatally, and can be acquired. Approximately 1.5 million people each year are affected by brain injuries. By age 15, 4 of 100 males and 2.3 of 100 females will have experienced a brain injury. Next, we'll specifically look at the Glasgow Coma Scale. It's the most commonly used metric scale for quantifying consciousness. And kind of to break that down a little bit, it has a point scale. Up to 4 points are given to describe an individual's eye response, 6 points for describing motor responses, and 5 points to describe verbal responses. For the individual's eye responses, 1 is meaning that the individual does not open his or her eyes, and up to 4 where his or her eyes open spontaneously. The 6 points for motor responses are from 1 where the person makes no movements, up to 6 where he or she obeys commands. And the 5 points for verbal responses go from 1 where they make no sounds to 5 where they converse normally. Typically, a severe brain injury is diagnosed in a patient with a score of from 3 to 8 when the coma lasts for 6 hours or longer. A moderate brain injury is diagnosed with a score from 9 to 12, and a mild traumatic brain injury is diagnosed with a score from 13 to 15. And that would be maybe a concussion or loss of consciousness for 30 minutes or less, would be considered a mild TBI. Next, we'll look at severity. The most common TBI is a closed head injury, in contrast to open head injuries. In the closed head injury, brain matter is not exposed or penetrated. Sorry about that. Let me back that up. Um, and such as rapid acceleration or deceleration, as in a car accident when people hit their heads on the dashboard or on the steering wheel. Among children, closed head injuries result most often from abuse, sports injuries, falls, and pedestrian vehicle accidents. Um, Language disorders resulting from brain injury are influenced by the severity of the injury, the site of the damage, and the characteristics of the child before the injury occurred. Here we'll look at the causes that I just went over for the closed head injury. And the risk factors that go along with those causes, participating in contact sports, using drugs or alcohol during during activities, or when driving or riding in vehicles. How are language disorders identified? Well, first of all, through an assessment process. We've touched on that a little bit in an earlier chapter. Um, Team members of this assessment process might include speech language pathologists, special and general educators, audiologists, pediatricians, psychologists, and certainly not last or least, but parents. The process will include a referral and screening. For children under 5 years of age, a referral for language assessment is usually made by pediatricians in consultation with the child's parents. Generally, these referrals are made because children exhibit a developmental or acquired disorder, such as Down syndrome or traumatic brain injury, that places the child at increased risk for language problems, or because warning signs signal the possible presence of a language disorder. Um, After following the referral, a screening is used to identify children who should receive a comprehensive assessment of language skills. It's often used to identify children who might be developing language skills more slowly than other children. There are several preschool and kindergarten programs who regularly conduct language screenings sometime during the year. I know here in Watauga County, the ASU Clinic actually has graduate students who go into some of the preschools in the county and in the fall typically and do these hearing and language screenings for children who are 3 and 4 years old, just to make sure that they're not falling behind their peers. Then following that screening process, um, if it is deemed that further assessment needs to be done through the screening, a comprehensive language evaluation will determine whether a language disorder is present. The evaluation develops a profile of linguistic strengths and weaknesses and identifies supports needed to improve language skills across affected areas. These evaluations will usually involve a case history, a comprehensive analysis of the child's language skills. The parents typically will fill out the case history from a questionnaire um, type form and may be completed in person or at home, and the parents might return that to the person who's conducting the evaluation. Um, Last, a diagnosis. Um, uh, the million-dollar question might be, how does somebody determine whether a language disorder is indeed present? And that answer comes through careful consideration of all of the evidence that's gained through the case history, interviews, comprehensive evaluation in all areas of a child's language performance. Also from the screening, um, evaluation of the evidence indicates whether observed problems are serious enough to be considered significantly different from normal and ensures that observed problems are not the result of cultural or linguistic factors. Once that decision has been made, for a language disorder is present, then the diagnosis usually designates the type of impairment, whether it's primary or secondary, which we went over a few minutes ago. The domains that are affected whether it's form, content, or use, comprehension, or production, and the severity ranging from mild to profound. Additionally, the diagnosis may include a prognosis statement. A good prognosis statement would say something about the disorder being likely to resolve given intervention, whereas a poor prognosis statement might state that a disorder is unlikely to resolve either on its own or with intervention. In some cases, professionals might withhold a statement of prognosis while they gather more information from other specialists, or they might have a period of observing how a child might respond to treatment. And these are just looking at those areas that we just went over. The importance of an accurate diagnosis. Obviously, parents are going to be hanging on every word, especially the diagnosis part of the follow up to a comprehensive evaluation. So you want to be very careful in making that diagnosis. Sometimes if an inaccurate diagnosis is given, there are two different scenarios that might occur. The first one being a false positive, where a child that does not have a language disorder is diagnosed as having one. And the second is a false negative, where a child who has a language disorder is not accurately identified as having one. Misdiagnosis happens for a variety of reasons. Um, could be poorly constructed tests or tests that are culturally or linguistically biased. Children might perform poorly during a language evaluation because of illness or fatigue, maybe because they're shy or because they have another condition such as ADD or ADHD, behavioral problems. Um, so, some professionals will misdiagnose language differences as language disorders. We've talked about that a lot in this class, and being careful about figuring out the difference between a language difference and a language disorder before a diagnosis is made, especially when children speak a non-standard dialect of English or who are learning English as a second language. So be really careful when you're diagnosing children that that they really have the diagnosis that you are giving them, because, like I said, parents will hang on to the words from that diagnosis. Dual language learners. Children who are bilingual under 5 years of age and acquiring 2 years, I'm sorry, two languages simultaneously are referred to as simultaneous bilingual learners. And then sequential bilingual learners are children who are over 5 years of age who have a native home language but are learning a second language. How are disorders treated? The nature of the impairment is going to drive the treatment. Treatment is tailored to meet the unique needs of the child in terms of target, strategies, and context. Treatment targets are going to be treatment approaches that are tailored to the unique needs of individual children in terms of target strategies and contexts. Treatment targets are the elements of language that are addressed during interventions. This is going to vary from professional to professional um, based on how they interpret best practice and, frankly, what has worked in the past from their experiences as a clinician. Treatment strategy is the way an individual approaches a task. It includes both cognitive and behavioral components. These treatment strategies describe the manner in which treatment targets are addressed. There are child-centered approaches. Um, the first one is looking at focused stimulation. This is one example of a child-centered treatment. With focused stimulation, the adult provides multiple highly salient models of language targets that are goals for the child. An example of this might be if a child is not able to request using the word want. The clinician will set up communication attempts in the context of play-based interactions to entice the child to use the word want. The clinician also models use of the word repeatedly. I want the cookie, the boy wants candy, the dog wants the bone. To make the word stand out, the clinician might say it loudly, emphasizing that particular word within a phrase or a sentence, or slowly or with dramatic pitch changes. During focused stimulation, the child's not required to respond at all. They're just expected to listen. However, the parent or professional arranges the environment and uses verbal techniques to entice the child's verbal participation and use of language targets. Focused stimulation is often used with young children, infants, and preschoolers, and can be implemented by parents in the home following training by a professional. Clinician-directed approaches are those in which the adult, being a therapist or a teacher or parent, selects the activities and materials and sets the pace of instruction. Rather than waiting for opportunities to occur that address a particular treatment target, the client deliberately structures a therapy session for frequent ongoing opportunities for the child to experience and practice a form, content, or use target. Clinician-directed approaches are useful for older children in particular and can be used to target skills that arise infrequently in naturalistic communication. Treatment contexts describe the setting in which treatment targets and strategies are used. They should include as many settings as possible to promote generalization of skills learned in treatment. That is the application of skills to many diverse settings. Um, for instance, children may experience treatment targets and strategies at home with their parents, in the classroom, with their teachers, and in a clinic setting with a speech language pathologist. Young children typically receive treatment at home because it's their natural environment. That's where they can learn best. Um, Older children receive treatment at school using a pull-out model where the child may be pulled out for individual sessions, or a classroom-based model where the specialist goes into the classroom and helps the child. Client and caregiver perspectives related to use of the natural environment. The reasons why the natural environment is considered to be the best setting, um, because it increases carryover. It respects the least restrictive environment, or the LRE, when the consultant or collaborative model is used. It involves the family. It produces more functional outcomes, and it enhances access to the curriculum. It increases discourse skills. Reading and writing goals for children with language disorders. Professionals that are going to be involved with targeting those goals are professionals such as a speech language pathologist, general educators, reading specialists, and special educators. The foundational skills you'll be working with will be phonological awareness, alphabet knowledge, print concepts knowledge, alphabetic principle, and reading fluency. And we're going to break those apart next, looking at each one individually. For phonological awareness, you're going to look at rhyme patterns and how to help children become aware of those rhyming patterns, such as bike and hike. We're going to look at syllabic composition of words, such as taking a 3-syllable word apart, like bicycle, and then asking them, what word does that make? And seeing if they can put it together and say bicycle as one word. Onset and rhyme boundary in single syllable words. For example, breaking a word up, ike, and being able to put those back together and say bike. Initial sounds in words. What sound do you hear at the beginning of bike? B. A child will be able to pick that out separate from the entire word. The next thing will be alphabet knowledge. In teaching children, you're going to want them to have knowledge of uppercase letters and uppercase and lowercase letter correspondences and letter sound correspondences. Letter sound correspondences would be like the letter N makes the N sound. Another part of alphabet knowledge is print referencing. It explicitly refers to letters while reading. This ensures that children can learn the alphabet letters in a meaningful way and can be used during shared storybook reading. Print concepts knowledge refers to rules that govern print. Knowledge of how books are organized. Where is the front of the book? Where is the back of the book? Where do words start? In the upper left-hand corner. A child could show you that they start in the upper left-hand corner. Wouldn't necessarily be able to tell you upper left-hand corner, but they could show you if you asked where do words start on a page, that words move from left and right. Functions of print in various genres and major print units. Adults should explicitly draw attention to functions of print when reading. We can encourage parents to do that with their children, to say, oh, look, that's a capital P. It's the beginning of a sentence. And then the rest of the letters are small. Or, oh, look, that's someone's name. It has a capital letter. Alphabetic principle addresses the following areas. Increasing child's ability to identify and blend individual sound sequence in words. Identify and blend familiar orthographic chunks, such as pre, meaning before, and view, meaning watch. So preview, meaning that you're going to watch something before or learn something before. To recognize words as whole units. To make analogies from known words to unknown ones, such as sight to fright. Intervention should be intensive, explicit, using examples that the child can understand, supportive for that child. If intervention is not supportive of the child and we aren't encouraging the child, then they are going to learn that reading is really hard for them. They're not going to enjoy it. So being very supportive of little small victories is very important. Looking at reading fluency, children need practice reading aloud. A therapist should match the child's reading level to materials when practicing. If reading material is too difficult, it's not going to be beneficial for that child when they're practicing reading. Reading at the independent level builds fluency. And that's meaning the level at which children are going to be able to recognize 95 to 99% of words automatically, and that their comprehension is high with what they're reading. Reading at the instructional level builds word recognition skills. And the instructional level is the level at which they recognize 90 to 95% of words automatically, and comprehension is at least 80%. So the instructional level percentages are a little bit lower than the independent level. Repeated reading aloud of independent level text builds reading fluency, whereas repeated reading of instructional level text builds word recognition skills. Both of these are important for helping a child learn and love to read in different types of texts. And that's the end of the PowerPoint and lecture for Chapter 7. Thanks for listening. Please let me know if you have any questions about what was discussed.